Newborn screening, what should be screened for and how? This discussion event has been made possible thanks to the kind support of Novartis, and everybody at the charity PET is extremely grateful to them for their support. The screening of newborns for disease has been performed in the UK using heel pricks and blood spots since the mid-1960s. And this has been the responsibility of the UK National Screening Committee since the mid-90s. Only 9 conditions are currently screened for this way in the UK in newborns. And this is fewer than in other high-income countries in Europe and elsewhere, where in some the number of conditions screened for exceeds 20 or even 30. And in recent years, patient groups and others have asked for new conditions to be added to the 9 that are currently screened for. But to date, this has not been done. Now, the use of whole genome sequencing for newborn screening is due to be piloted in the UK by Genomics England and could yield great benefits. But that approach will take time, a substantial amount of time, I think, to be developed and then assessed and then rolled out nationwide. And PET is really pleased to announce that we're going to be producing a series of 5 events in conjunction with Genomics England in relation to this project, the first of which will be taking place 2 weeks today. Because I think that, there needs to be public discussion, because this is a step change in how we screen newborns if we're going to move to whole genome sequencing for everyone. But to be very clear, tonight we're not focusing on whole genome sequencing at birth, because I think before this is rolled out, discussion remains to be had about the conditions that are screened for in the here and now, and using the established methods and processes that we have. Now, some argue that opportunities to detect rare diseases are currently being missed in the UK, including in instances where perhaps an early intervention could make a significant difference to the outcome or outcomes for the children that are affected. So I'm going to now stop talking about the subject, because we have 4 fantastic speakers for you this evening to discuss what should be screened for and how in newborns. And those speakers are Professor Anne Mackie, Professor Laurent Servais, Dr. Will Evans, and Nick Meade. It gives me great pleasure now to introduce this evening's first speaker, Professor Anne Mackie. Anne is Director of Programmes at the UK National Screening Committee, which supports the government to make evidence-based, safe and acceptable health screening programme policy throughout the UK.
I am the head of the UK National Screening Committee Secretariat, and we have literally just moved to the Department of Health, which is partly why I'm so flustered. And the UK NSC itself has been through a recent review to see whether and if so, how it should be refreshed in light of various changes, possible changes like targeted screening or differences in technology. I will leave you these slides, but the UK NSC has got a published process of how it goes about assessing evidence, but it's a independent scientific advisory committee, and it looks at screening conditions right the way through the life course, from maternity through to we suggest screening diabetics until they're no longer with us. So right the way across the life course, it's accountable to the 4 chief medical officers, and it uses a set of criteria which have been essentially set out from Wilson and Jungner, so from the WHO in the early 60s, and they've been through a variety of iterations to take on genomics, for instance, or informed choice, but nonetheless they have reasonably stood the test of time and a couple of public reviews. And as I've said, we've moved to the Office of Health Improvement and Disparities, affectionately now known as OHID, at the Department of Health. but the committee itself remains independent of any of the English departments of state. So the UK and newborn screening. This is not the first time that I have been reminded that the NSC recommends positively screening fewer than some other countries. And I think that it's difficult. The screening is not to some extent relies on science, but also relies utterly on the ethical frameworks in which the health services work, and also the health services themselves. So if you haven't got an end-to-end health service, and you haven't got a call recall system, and you haven't got a national way of making recommendations, you will not run them like us. And there are relatively few places in the world that have that set of contexts. So comparisons, I find, can be quite difficult and quite, they ask lots of questions, and we need to be careful that we look at, when we do compare ourselves, whether it's a reasonable comparison. So we have so the terms of reference are set out. What we are supposed to take into account is set out. It's not whimsical, and we take a public health approach to this, and we take harms into account as well as benefits. And often when you look at this from the point of view of being a parent with a sick child, or being ill yourself, the focus on harms which may seem difficult, but nonetheless, that is what the NSC is required to do. And because there's been this debate between the NSC, the Secretariat, and organisations such as this, we have undertaken to look at how the NSC makes recommendations in regards to the evidence. And so we did ask for a systematic review of how countries go about making decisions. It's remarkably difficult to find out, actually, because these sorts of things are not published. But and so it was quite difficult. But a review was done which found that 42% of recommendations about whether to screen for babies don't take account of evidence on test accuracy. So we know that if you've got a poor test, you tell children and their parents that they're at risk of something which they're not, that they are ill if they're not, and you risk misinforming people that they're okay. And it's extraordinary that that many recommendations would not take whether it's a useful test into account. A third don't review evidence about whether early treatment improves health outcomes. Again, that seems extraordinary. The entire point of screening is to find something earlier to improve the outcome. They are expensive and difficult things to do, and we should aim them at places and conditions where they will genuinely make a difference. And 3/4 don't consider the evidence around potential harms or overdiagnosis. Now, we know that the TMS, the current system, will say to people they have got markers of potential illness, and we know that a good proportion of those will not go on to be affected at all, but there is a concern that using whole genomes will make that even more so. So while they might have a genetic error, they may not have the biochemical marker. And of course, I talked about the context. The NHS is end-to-end. We've got quality assurance processes, which are the envy of the world. So I think we feel, and we continue to reflect and talk to people, but I think we feel that the way in which the evidence is reviewed and discussed is good quality. So we and to focus on the point about quality assurance, we make absolutely sure that we find everybody, they are offered. Of course, people can decide that they don't want screening, but it's well in the top 90% of people that do, and that we make absolutely sure, wherever possible, that we do not lose people along the pathway. It seems to me that if we fail to invite people we ought to invite, then that is awful, and particularly if we don't follow children up who have got the illness, it's catastrophic, of course, if the child's not cared for, but it's awful if we do tell a parent that their child is not well and we don't follow them up. And so we have set up various systems right the way across screening, but in the blood spot programme, we've got a fail-safe programme to do exactly that. These things are not common across the countries with whom we are compared. Right. We do attempt to screen for the right conditions. So if a condition looks promising as a candidate for screening, there may well be ways in which we cannot be sure that we're going to do more good than harm. And we have found increasingly that evaluating it in real life is a way to try that out. Now, I make a distinction between evaluation, which is where we have got good cause to think that that is a usable thing. So the Germans did some blood spot things, and we adapted them and tried them out in the most recent 4 that we added. But we sometimes do proper research in service evaluations where we try to where we develop new evidence, and I'm hoping against hope that we can do that with the whole genome sequencing. So we did that with MCAD, particularly unpleasant metabolic error, and found that we were able to find some children earlier, and that we improved their outcomes, and that's fantastic. That's exactly what we want to do. But we were very careful to make sure that we told the minimum number of people uncertain results, and we, as far as possible, got false positives ironed out. You do not want to be told, we're a bit worried your baby might have this thing. If it's sick, it's not eating, it's grumpy, then take it to A&E, because what little I know about babies is they're always like that, and you do not want to be hovering over your baby if you're not sure. These have got real consequences, so we have to be careful. So the evaluation was favourable, and that was added. And I say we did a separate one, looked at 5 other metabolic disorders. These come from organisations who are going to be speaking today, but also from clinicians who say we think these are areas where we've got a good test, we understand the disease, and we are confident that we've got good quality care. We assess those, and 4 of those we've added. And we are currently evaluating screening for severe combined immune deficiency, babies born without white cells. And we're hoping very much that that will turn out to be a cost-effective thing to do, and we can absorb that into the programme. And we're about to consult on tyrosinemia screening. So we continue to look at screening for new blood spot conditions. So you say that we screen for 9 things, and we do, but we also find a series of other conditions as part of the screening programme. These are secondary conditions, and some of them we find the overwhelming majority. I think we find almost all the beta thalassemias. And if we do find any of these, they call secondary targets. It's not a particularly nice way to describe them, but they're not the point of the programme. But when any of these are found, they are referred instantly, just as they are with the primary targets, to clinicians, so that the babies can be followed up, and they're subject to the same quality assurance processes. So we are talking, you rightly say whole genome sequencing might be a little way off, but we are working very carefully with Genomics England and NIHR to see whether we can support the whole genome sequencing to make really good quality research that the NSC can simply absorb and say, great, it looks like it's a good idea, let's absorb that. And we're talking to Genomics England about that. And we also asked and worked with Genomics England to do the newborn dialogue. Screening using whole genome sequencing is incredibly important, but whole genome sequencing has many more consequences or issues than simply screening. And so I think it's very important, and I'm delighted. That's a really useful, really important piece of work where the people who are involved have really got to the nuances and are pushing us all to think quite hard before we step out into this. And I'm really hoping one of the big problems with the blood spot programme is that we don't have good quality research. So someone comes along and says, we really want to screen for this, and we say there are some evidence gaps. Can we help you work with the HTA to do research? And that simply hasn't worked. And I'm really hoping that with the whole genome sequencing, that we will be able to make that happen. And I'm very optimistic indeed. Genomics England have been very keen on taking that forward in that way. So we've also been looking at the use of genetic processes in the cystic fibrosis program to see whether we can use genes to characterize screen positives, whether it's better to do that than the current system. And again, we've done a dialogue with people about that, and very interesting indeed, actually. There's a trade-off between getting fewer people with unknown significance of the screen positive findings, and people were the public who talked to us about that were very keen that we tried to minimise that. They were looking to minimise uncertainty, which was slightly unexpected actually, but really it shows when we talk to people and involve them, we get really useful and helpful input into the screening programmes. I'll leave you with these. And so we are working on the blood spot work on blood spots. They are extremely important. I think they're the biggest cluster of things that we recommend screening for, and we are aiming to do a whole series of things in there. I've talked about the whole genome sequencing and the development of research processes. We did recently see the Eurodis checklist. I wasn't aware of it, but I was on a blood spot conversation, and we thought we should check how the NSC goes about its business properly against how Eurodis have suggested. Working with the Netherlands on screening tests, I've talked about those. It's to develop tests in a way that the NSC can simply absorb. Talking about modelling exercises, we know that we're never going to get an RCT of the treatment of maple syrup urine disease, but how we can get input from people who suffer from the disease, their parents, and from expert clinicians to make sure that we understand that properly in the patient's stories is incredibly important, and also to help on developing useful registries. We've been talking to ALD recently because I think they're about to set one up, and how we can work with them to make sure that the registry both, of course, helps them, but also provides it the sort of input that the NSC can use directly.
The first question from Michelle Levine is, what is the viewpoint of the UK NSC regarding evidence derived from other European countries, such as evidence from NBS pilots? Can peer-reviewed published evidence and analysis from other European countries be taken into account as part of your considerations at the UK NSC?
Absolutely. Any decent data, any decent evidence, we will absolutely absorb. And so in relation to the severe combined immune deficiency, we have got somebody from Netherlands sitting on the board advising us on the evaluation. Absolutely. And I did say that that we used input from Germany, who do a number of these things. Now they use the tests at 2 days, not 5, and I think that matters in some. So we tried the test they used the data that they provided and applied it in England or in the UK. So absolutely we do. Yeah.
And then one from Francis McGlone. Is whole genome sequencing going to be target gene led or a fishing exercise? The latter can be problematic.
Now, I'm not going to be running the genome sequencing thing, but I am very pleased to say that the Genomics England are going to try and look for specific conditions. So there will be a conversation as part of the Genomics England pilot thing, which says which do we think are treatable conditions. We're going to look for treatable conditions. They're first going to send them to the NSC so that we can do our normal triage and say, we've got prevalence, natural history, decent test, treatments in screen populations. And if the answer is yes, we will hoover them up and pursue them down the NSC route. And if there are evidence gaps in those, then we will suggest that they go part through the Genomics England research process so that we can learn. I am very hopeful indeed that it will not, I'm sure it's not going to be a fishing exercise, absolutely not. The last thing we need is to be burdening new parents with, I'm afraid your baby's got 5,000 genetic errors and we don't know what 4,998 of them mean. That would be unkind.
And this is from an anonymous attendee. For those of us who've used donor sperm, we often know a lot about the donor, including genetic testing. If a donor has been screened and we know they're not a carrier of certain things, does that reduce the risk of the newborns needing screening? I.e., do both parents need to be carriers for a newborn to be potentially have something wrong?
Where we're confident that two genetic variations add up to a problem, then absolutely, if only one of the parents has got the variation, then absolutely not. But we do know that it is possible to have one CF variant in one parent and a different CF variant in another parent, and that adds up to CF. So it's not a guarantee. I think the other thing about screening is it's a volume business. We do 600,000 babies. And so the more complicated we make it, particularly if it relies on the individual to come and get themselves tested, the more likely we are to miss things. So the joy of, in a way, of the blood spot program as it is we say, right, we're going to look for this lot, and it's shoved through the machines, and we quality assure the machine, so we're absolutely bang sure that what we get out is what's there. I say, if we start to make that more complicated, we're very likely to miss people, and that again would be catastrophic.
Our next speaker this evening is Laurent Servais, who is Professor of Paediatric Neuromuscular Diseases at the Oxford Neuromuscular Centre, a partnership between Muscular Dystrophy UK and the University of Oxford.
Thank you very much. I'm going to give you a slightly different point of view, the one of Anne. And it's the point of view of a physician who see on a daily basis these patients. I've got a couple of disclosure. Please take a screenshot. These are my patients. These are my patients with spinal muscular atrophy. They are, most of them, normal at birth, then they develop weakness, proximal, and difficulties in breathing. That's the most severe form. This lovely baby with bright eye will die in a couple of weeks. These others have a milder form, if we can call milder a form in which you will acquire the sitting position, but not the working position. And there is even a milder form, if we can call mild, a form in which you acquire ambulation and then you lose it. This disease affects every 5 days a child in the UK, which means every 5 days a child is born with this disease. There are about 70 per year in the UK. So these patients, all of them are intelligent. There is no intellectual disability. And the beauty and the strength of this disease, and I will not go into the detail, but they all have the same mutation in the same gene, which is SMN1, and which is a deletion of exon 7. There are 5% of exception, but let's keep in mind that they all have the same deletion in the same gene, which makes a perfect example for PCR-based newborn screening. This is a patient of mine. Look, he has a typical SMA type 1B. He has a nice kid, smiling, clever, but already paradoxal breathing. And in absence of treatment, these patients will die within 5 months. But he was fortunate. He could be part in a double-blind randomized placebo-controlled study. And for the sake of time, I just show him 3 years later. He's not dead. He's now able to walk with assistance, because today we have nearly no patients who have been treated after the symptoms who are able to walk. And this patient survived. He survived with a non-invasive ventilation. He survives with a wheelchair and with a very significant investment from the parents and from the society. And then I met this family, and this family is actually a family where both kids have the same disease, SMA type 1. This little gentleman was treated after the symptoms, and now he's doing better. He survived, and he's able now to keep the sitting position. He will never walk. But the little princess here, with the sister, has been treated at birth because we knew she was affected, and she's one of the first patients who has been treated before the symptoms. same disease, same treatment, total different fate in life. And you can say, okay, that's fine, but you know, she's 1 year old, and what's going to happen later? Well, as I told you, she's one of the first patients who has been treated before the symptoms. And here is the same little princess 1 year later. She's not dying of SMA type 1, you will agree. And we don't know how to see how normal she is. And these are the same kids, the same family. The last video I received from the parents, and this is the magnitude of effect between a patient who has been treated after the symptoms and a patient who have been treated before the symptoms. That's the magnitude of effect we're talking about. We're not talking about some points on a scale. We're not talking about doing a little bit better. We're talking about being completely normal or being in the wheelchair. And this is another family of my patients with the older sisters who have been treated after the symptoms. And this one, look, that's how she climbs the stairs. This is the magnitude of effect we're talking about, a normal patient and a patient in the wheelchair with a non-invasive ventilation. So we have another approach that has been published in these patients have been treated with oligoantisense nucleotide. We have another approach that has been published at the same time in the New England Journal of Medicine, which is gene therapy, and which is now available in the UK. Let me tell you two stories. Jack, born in Belgium, and John, born in France. They have both the same disease. John, the French one, has been treated after the symptom. Look, he's doing much better. He survived. At the age of 11 months, he's 15 months, is able to eat by himself. And I received a picture of him, very nice picture. He now is at school. He's, of course, wheelchair bound, and this patient will probably never walk. And his counterpart, Jack, born in southern Belgium, where we screened for 4 years now, was the first patient in Europe to be injected before the symptoms with a gene therapy. He was injected at day 41 in my hospital in Belgium. And that's the same little gentleman a little bit later, actually 9 months and a half after injection. And this boy, as the others with 3 copies of SMN2 who have been injected before the symptoms, is normal, is doing perfectly well. We have another approach, which is risdiplam, recently published in 2 nice papers in the New England. And this is, again, what we're talking about when we talk about a patient with SMA type 1 who has been treated after the symptoms. Little princess from my clinical trial, I was investigator, and look, she's doing better. She has the sitting position, but she has a non-invasive ventilation at night. And now she's 4 years old and she will not walk. She's not a walker. And this little princess is treated for the same disease as the same medication. And she was the first patient to receive risdiplam at birth because she was identified by newborn screening in southern Belgium. As you might imagine, when you have such patients, you think every day about newborn screening for this condition, and you dream every night about newborn screening for this condition. It is 1 kid every 5 days in the UK. So we start March 2018, the pilot in southern Belgium. You can follow it on Sun May Arise on SMA. And we could detect 150,000, we could screen 150,000 newborn and identify 12 patients who were successfully treated and who are doing perfectly well. If these patients had been treated after the symptoms, they would be at best wheelchair bound, and for many of them with a non-invasive ventilation. So newborn screening for spinal muscular atrophy is more and more implemented in the world, with many publications that are coming. That's different pilots everywhere in the world. And that's a survey that we recently made with my team. And we found that so far, at least 3,674,000 newborn have been screened across the world, with 280 cases who have been identified. And only in the 2 very first pilot, they were false positive. But since this very false positive and this very first pilot, there were no positive and no false positive and no false negative, which makes it probably the most secure screening that exists. And we could estimate that today 3% of the world population is screened for spinal muscular atrophy, and probably something like 30% should be screened within 6 years. Let me submit you just a kind of small calculation that is extrapolated from my data in Belgium. There are today 72 newborns per year in the UK with this condition, 1 every 5 days, 72 newborns. Here they are, and behind all of these patients, there is a family, right? In absence of treatment, but this is historical, that's the results. 44 will die, 23 will be in the wheelchair, 5 will be ambulant. But nowadays we have a treatment. We can treat them after the symptoms because we do not have newborn screening in the UK. And that's what we have. 90 will die anyway, 38 will be wheelchair bound, and many more will be sitters. If we could screen this baby, and if we had the same result than in all the other countries like the US, like Germany, like Australia, like Southern Belgium, in which we screen, out of these 72 newborns, we could not do anything for 2 of them because they have a very early form. But for the others, the vast majority of them will be workers and will be in excellent condition. So that's actually the difference between the 3 scenarios. But today we can treat these patients. We can treat them after the symptoms, which means that if we do not start screening quickly every year, we are building a snowball of patients in the wheelchair with non-invasive ventilation. And you can imagine the burden on the healthcare system. So I've got a PhD student in Belgium. What she does is counting. She counts every single pennies that these patients cost when treated after the symptoms and before the symptoms. So I'll bring you some data. And I don't have the time to go through it. But I made a calculation from you, and this is extrapolation of our data in Belgium. The yearly cost, if it's the same cost than in the UK, would be €2,500,000 per year for the UK. And if we have the same effect than in Belgium, the total cost saved per year would be 143 million, which makes newborn screening for SMA in countries where there is a treatment for SMA the best investment ever, much better than Bitcoins or Amazon shares when it was introduced on the stock market. The best way to use the taxpayer money is to invest in early detection and early treatment. And I made this small calculation for you just to understand that if we don't care of considering that every 5 days a patient is let without early treatment and will spend his life in the wheelchair, even if we don't care, we should screen for money because each minute waiting for NBS in the UK costs €272. I am provocative. I appreciate I am provocative. I am using our data over 3 years in Southern Belgium and some data from Australia, but this is the magnitude of effect we're talking about. So I know that we have a process that is in place in the UK for newborn screening, but we are also in a country where we can ask the government and we can ask the parliament to consider something. And please take a moment, not only to sign this petition, but also to promote this petition, to send it to your network, to your address network, because we need to make things moving for these patients. And that's the example of SMA, but what we've done for SMA, we cannot do it for all of the disease. Let me show you one of my patients who was supposed to have SMA. He has not SMA. When you know this kind of disease, you identify quite quickly a congenital myasthenia. And this is the same patient 2 days later on salbutamol. And I can tell you that today is perfectly normal after 2 days of treatment of salbutamol that costs £6 per month. So we have 3 other patients in our centers, and altogether, these patients spent 70 years in the wheelchair. They've been invasively ventilated for 30 years. They had 5 muscular biopsies. They lost over 50 years of productivity. They require several hours of adaptations. All of this, including the 20 years on ventilator, could have been avoided if we screened for this condition. So what we've done for spinal muscular atrophy, we cannot do it for every single disease. This is just impossible. We need to change the process to be able to treat and to treat early and to get the best leverage to treat the disease that we can treat today and a disease that we will be able to treat tomorrow. In Southern Belgium, it means today for the disease we could treat and that we do not screen 15 patients per year. So if you extrapolate to the UK, it's more than 150 patients per year that we could treat and that we do not treat, that we do not cure, even if we could. So we initiated this project now in Southern Belgium, which is called Baby Detect, with the aim to screen, to detect, and to treat at birth 121 diseases that are perfectly treatable at birth and that we do not treat. We need to change our understanding of newborn screening and being able to accelerate our process to make it available for the babies and the families that are affected by rare diseases. Thank you very much for your attention.
Let's move on now to tonight's next speaker. We have Dr. Will Evans. Will is a GP and he is Chair of Trustees at Niemann-Pick UK, and he's clinical lead at Mendelian Health and also a healthcare researcher at the University of Nottingham's Primary Care Stratified Medicine Research Group.
Yeah, thank you for the opportunity to speak today. As just been said, I'm the chairman of Niemann-Pick UK, and most importantly, for the purpose of this conversation, the father of Sam, who's 13, who has Niemann-Pick disease type C. I'm actually not going to use any slides, so if you're wondering why you can't see any slides, that's why. So don't start clicking around on your screen, seeing if you can find them. I'm going to try and speak from the patient community perspective of the impact of having an early diagnosis, such as can be achieved with a newborn screen. My experience and what I'm going to describe is based on my first-hand experience and a deep knowledge of the disease my son has. However, the key message I believe are applicable to many other rare diseases and many other rare diseases suitable for newborn screening. As we've just heard before with patients who have a readily available therapy and often a long time receiving inappropriate treatment before they receive the accurate diagnosis. Something that is commonly expressed is to consider newborn screening with a far broader view than both the individual affected and their access to disease-modifying therapy. So indeed, at Niemann-Pick UK, we actually rarely refer to affected individuals. We talk about families who are affected. And I really do strongly feel it's in that context that newborn screening should be considered. A little bit about Niemann-Pick diseases. They're ultra rare, inherited metabolic diseases, one of more than 30 lysosomal storage diseases. And there's approximately 130 people affected in the UK. Niemann-Pick type C, the disease my son has, is the most common. And it's a progressive neurodegenerative disease, sometimes referred to as childhood Alzheimer's. That description is not entirely accurate, and the disease can be variable, but in its classical presentation, the majority of patients, there are lots of similarities, and it is a cause of childhood dementia. So a child with classical NPC is typically developing normally and starts to have problems as they start school. They're often first described as being clumsy, and then as this disease progresses, they develop an ataxia, pronounced unsteadiness and incoordination of movement. They sometimes develop other symptoms, including a thing called cataplexy, which is a form of cataplexy called gelastic cataplexy, where you lose muscle tone with emotional stimulus. So often that means that people literally fall down laughing. When they laugh, they lose muscle tone, they collapse. As the disease progresses, they develop problems with eye movements, dystonia, so that's abnormal muscle contractions, abnormalities with their speech, their swallowing, seizures, which are often treatment resistant, and the dementia that's already been described. And the disease continues to progress until they're dependent on care for all their activity of all of their kind of normal day-to-day cares. Patients with classic NPC typically die in their late teens or early 20s. Now, one thing which is of great hope in our community is there's a significant amount of research and interest in drug development. There's a licensed therapy, miglustat, which is available in the NHS, and it's licensed by the European Medical Agency. There's a further drug going through final approval processes in Europe, and there's multiple clinical trials either in process or in the preclinical phase. And indeed, there's early preclinical work about gene therapy for Niemann-Pick type C. The likely goal for Niemann-Pick type C in advance of potential gene therapy will be multiple combination therapies. But like lots of degenerative diseases, timing of treatment is key. With a neurodegenerative disease such as Niemann-Pick type C, when the neurons have been lost, they can't be replaced. So a treatment that slows or stops neuronal loss and disease progression needs to be started before the disease has progressed, just as we heard with spinal muscular atrophy. Early treatment is absolutely key. For the majority of patients, their diagnosis falls long after this, and indeed, potentially after what I would even call a meaningful window of opportunity, when their disease is already significantly advanced. And although the diagnostic delay from first neurological symptom has improved, it's still typically 3 to 5 years from the onset. But in many patients, this is far longer, and a sizable proportion are never accurately diagnosed. Now, newborn screening is a potential solution for Niemann-Pick type C, so it's technically possible using a kind of a multi-tiered approach. And Niemann-Pick type C, along with 14 other diseases, also actually included acid-sphingomyelinase deficiency, which is another form of Niemann-Pick disease, is part of a consented research study called Screen Plus in New York. These 14 diseases on this Screen Plus panel are actually in addition to the more than 50 diseases that are part of the standard New York State screen. And in the US, there's a vocal patient advocacy group called the Firefly Fund pushing for its wider adoption. And the inspiration for them is essentially having a first-hand experience of seeing the benefits of early treatment. This is quite common in our disease, where a family, the disease is an inherited condition, autosomal recessive, have multiple children affected. And they have first-hand seen the divergent path that their two daughters have taken, the elder one being diagnosed after a long delay, the younger one being diagnosed because of her sister when she was still pre-symptomatic. So really the key purpose of my talk is to emphasize that additional benefits beyond starting a disease-modifying therapy of achieving a very early diagnosis of diseases such as Niemann-Pick type C. You know, in addition to the example I just said where siblings are affected, where the younger one before the onset of neurological symptoms, in Niemann-Pick type C, a proportion of patients are actually diagnosed when they're newborns due to liver disease. Typically, patients with liver disease recover from this with simple supportive care and then have a number of years where they can be in relatively good health before their neurological disease starts at the age of 5 or 6. And this is actually, in addition to the sibling, has given our community an ability to compare those who receive an almost pre-symptomatic diagnosis from a neurological disease perspective from those who don't. And indeed, that was the case for our son, Sam. Sam was born in 2007. And when he was only just a few weeks old, he had persistent jaundice, and a simple test arranged by the midwife, a split bilirubin test, showed that it wasn't just normal breastfeeding physiological jaundice. And that led to a diagnostic workup and an admission to our local liver unit. A long way down a very long list of potential causes was Niemann-Pick type C. And Sam was poorly enough for the clinicians to keep working down that list. Had he had milder disease, which many children with Niemann-Pick type C have, they often wouldn't get far enough down that list. So we actually received the diagnosis when Sam was 4 months old. By this time, Sam's liver disease was much improved. And as devastating as that diagnosis was, it enabled us to understand and have a reason for the problem Sam faced. It also enabled us to get disease expertise from the Willink unit, be involved in clinical trials, and also invaluable support patient advocacy group that I'm now the chair of. It also, by getting the diagnosis at that young age, the youngest patient at that point in the UK, it gave us the opportunity to plan in knowledge of the challenges we knew we would face. So the choices about where we would work, the roles we took, could be informed by having this timely diagnosis and being equipped with that knowledge. So crucially for us as well, with Sam being our first child, it enabled us to make reproductive choices. As a genetic disease, inherited in an autosomal recessive pattern, each child we had would have a 1 in 4 chance of being affected. And as I've said before, many families have multiple children affected by this disease. We knew the risk, and therefore we could make the right choices for our family. And for us, this was going through PGD, pre-implantation genetic diagnosis, which is a process where an IVF process and then selecting embryos at a very early stage that you know are unaffected. And as a result of that, so in 2010, we had Sam's brother and sister, Sam and Ellie, were born, who are now 11. Now, there are other candidate diseases which I think are significantly higher up the list of being adopted onto a newborn screen, including other lysosomal storage diseases such as Pompe disease and MPS 1, which are widely adopted in multiple countries. However, I think our personal experience does emphasize the value of early diagnosis, and that diseases such as Niemann-Pick type C and all of these others have an impact far beyond the individual affected. Certainly, I feel that the assessment of newborn screening currently doesn't give sufficient weight to this broader impact, and that the true value of newborn screening can only be realized when it's considered in the context of the wider family. I'm aware that kind of in helping other diseases move through this process will also enable when our to potentially being adopted, that it can be adopted more quickly. You know, currently I feel that the process just takes too long, and many rare diseases fall into this catch-22. The appraisal of evidence often reports a lack of natural history of the disease, especially in its early stages, to know whether diagnosing early is worthwhile, and that the additional benefit of early treatment is not strong enough. You know, as we just heard with spinal muscular atrophy, the absolute impact of early treatment could only be realized when you started diagnosing patients pre-symptomatically. But indeed, you can't get to that point until you have a newborn screen. So you have this catch-22, that you can't get the evidence to move it through the screening committee until you have a newborn screening to actually give you the information that answers the questions that they want asked in advance.
Nick is the Interim Chief Exec and Director of Policy at Genetic Alliance UK, an organisation that PET's worked with many times over the years. And Nick is co-chair of the Rare Diseases Coalition, which has produced a new report on how best to implement the UK Rare Diseases Framework.
I thought I'd just, I think following the three speakers I'm following, I've got a bit of an open goal here, but I thought I would just underline why this topic is so important to our community. So, as Sarah said, we're the largest alliance of organisations supporting people living with rare genetic and undiagnosed conditions. We've got more than 200 patient organisation members. We've put in quite a bit of work on this topic. We've published a patient charter on the topic in 2019, and we're supporting the Archangel Screening Alliance campaign, which I'll come to in a little bit. I want to start just with this international comparison. So where do we actually stand internationally? Anne touched on this, but this year we got a new publication from this esteemed group who counts screening in Europe, and I've taken their data and put together a graph, which I think shows the scale of the difference. And I think it's worth actually dwelling on this a little bit, even though Anne has covered off her response to this. So the UK is a little to the left of the middle in the graph, with a black line around it. I've coloured EU countries in blue and non-EU countries in orange, just to give some meaning to which countries are where on the graph. But I don't think it's that important to actually pick the specific countries, but more just to look at how many European countries are screening more conditions than us, and the actual difference between the two now. So there's this wedge above us that are screening for up to 10 conditions more than us. And I'm prepared to accept that there might be some countries that are screening for too many conditions, perhaps by some criteria, but it feels like maybe the answer to the question that we've been set today might be that we should be screening for more conditions, and that certainly the tools that we're already using for screening, the conventional methods, still have some slack in them to get some more conditions on the list. So just interrogating that data in a different way, we can look at which of the conditions that we could move on to and screen for. So ranking the conditions that are screened for across different screening programs, and just to acknowledge that obviously when you count things, you can count things in different ways. So some of these numbers might not correlate with everyone's. I forgot to say what the green things were. They're pilot programs, by the way, and that's the plus number on this list. So the blue lines here are the ones that we're screening for in the UK. And you can see, again, there's a kind of a obvious set of candidates, and this list is very long, so I'm not showing them all, that maybe we should be looking at and examining whether these are the conditions that we should be screening for alongside other countries in Europe. Tyrosinemia is a condition that Anne mentioned that the UKNSC will be looking at in next year, I think. And just to note, that's a condition by condition process, which maybe we'll come back to. So this is the other end of the list. And I think it's really interesting to note that SMA is actually near the bottom of the list. There are these pluses of pilots, and this data might be a few years old. So this isn't to contradict Laurent's presentation. But just to flag, actually, we are taking account of the needs of our population and screening for sickle cell disease, unlike many other countries in Europe. But also, these starred ones are conditions that I'm aware of cell and gene therapies being either available or close to access. And you can see that's where some of the highest numbers of pilots are, which are these. This is countries spotting that we're going to have a powerful treatment on the horizon. Let's get our diagnosis pathway sorted out, maybe before that treatment arrives, and not wait for it to arrive, as the UK has done with spinal muscular atrophy treatment. I just want to have a look at maybe, I mean, and trailed this as well, but these are the petitions. Laurent's mentioned his one on the left here, and we also had one for ALD. The government's responding to these, and we actually found the response a little bit depressing, because the government's doubled down a little bit on the current approach in the UK and isn't really flexing. It isn't responding to say, we accept that we could do more, we could adjust our process to get that balance right. As Anne says, we've got a balance between the harms done in screening and the benefits. And it feels like there are a lot of countries around Europe that have that balance set a little bit differently. Will spoke about some of those benefits that he sees in the in screening for Niemann-Pick, and I think that we could have our balance in the wrong place. This response from the government, you can read it if you click through to Laurent's petition. It was written before it finishes because they reached 10,000 signatures. We can get it up to 100,000, and then I think there'll be a debate in Parliament on the topic, which would be really valuable. But as I say, the government response is really kind of digging its heels in and not really proposing any changes, which is a shame. And this kind of sense of robustness isn't a good thing for people living with rare and genetic conditions. And this is maybe stating the obvious, but populations of rare conditions are very small. And actually the kind of conditions that fall into the basket that we're talking about at the moment are also highly variable, often very severe. A lot of them affect children, and there's an awful lot of them. There's more than 6,000 of them. All of these combine to make actually collecting evidence about the conditions quite challenging. And it can mean if you apply the same evidence thresholds to rare conditions that you apply to common complex conditions, rare conditions don't do very well. And to react to that, there are multiple organizations that make decisions about health that have adapted their pathways or created separate pathways to make decisions about rare conditions. And the newborn screening pathways, so all blood spot conditions are rare, and all of these are rare condition decisions. We're using essentially the same criteria we use for adult screening for much more common conditions. And I just want to reflect, actually, that we've heard a little bit about Genomics England's work to understand what the value of newborn screening using genome sequencing might be. And I think the approach there is really interesting. GEL are taking a technology and they're consulting a population and saying, what can we do with this technology? What's achievable? What might we put on the list? Why would you want it on the list? And what would the value be? Whereas the UK NSC open a gate for 3 months of every year for people to propose individual conditions that are then addressed one by one. And I think, if you look at that 6,000 number there, that might be another reason that we're holding it ourselves back here. And if the UK NSC were to actually just examine the technology that we've got and say, what could we achieve with newborn screening, then we might be able to make some more progress. I want to finish just by underlining the value of newborn screening to our community. And I know I don't have much time left, Sarah, but this is my second last slide. Timely treatment. So Will's spoken about this, and I think Laurent's provided some of the most powerful evidence you could ever hope for, that getting that treatment there on time is really, really important. It also, though, brings information and gets a diagnosis to families much sooner than they might do. This is something that you can easily, I guess, ignore the power of. Many of our communities in Genetic Science UK have families that regularly spend years looking for a diagnosis. So, and using the NHS to do so with many scans and treatments and so on. So actually getting a diagnosis when maybe the treatment might only be management is still very powerful. And Will also touched on some of the family planning options that do become available once a couple become aware of their risk of having a child affected by a genetic condition. And then finally, and this was also touched upon by Laurent, but I thought it's worth laying out here, the wider benefits of having a screening program really do mean that we learn a lot more about our society's relationship with rare conditions, and we can start building the world that starts solving those conditions. So we can be a much better place to host clinical trials, which is something our current government's very interested in doing, collect data, study these conditions, and just be in a much better place. So to answer the question we've been set today, what conditions should we be screening for, and how? I would say probably more than we're doing now. And there's definitely some conditions that we could be screening for using the current technology.
So this is from Shamina Rahman, and she asks, what is the definition of a treatable condition? I don't know who wants to have a stab at that first. Perhaps Will, do you want to have a go first?
Yeah, I mean, I think that's a really good, a very simple question, because I think sometimes what's framed as a treatable condition is too simplistic, and I would say that almost all conditions are treatable and certainly manageable. In actual fact, it being equipped with the correct diagnosis does enable you, even if there is not any disease-modifying therapy, where there's clinical trial evidence that changes the trajectory of a disease, that actually knowing the correct diagnosis and doing simple things better as a result of that, whether that be following guidelines regarding optimization of seizure controls, or being aware of the full breadth of the phenotype, so you can ensure that their kidney function is working fine, and that you're reviewing their liver disease if that's a feature of it. I would say that all diseases are treatable to a point.
Nick, I'm guessing
Yeah.
you're going to want to come in on this.
Just to augment Will's point, I think the Eurodis campaign on newborn screening, and I think Virginie's put a great description of that in there. The wording used there isn't treatable, it's actionable. And I think that's a lot more useful to think about, and covers the scope of the value that we've been talking about today much better. So I prefer actionable rather than treatable, and I think hopefully the basic meaning of the word explains where a condition is actionable.
Laurent, do you want to add?
I think that this is an excellent question. Of course, we had to make this exercise disease per disease in our program in Belgium to define the disease that we want to take on board for the screening program Baby Detect, and to finally retain 120 diseases, which was many more than expected. So as you might imagine, they are all shade of grays between the disease for which you can absolutely not do anything except being kind, and the disease that you can perfectly treat, even cured. And there's all possible intermediary between both situations. I would personally, the way we did was to consider treatable conditions to be included in our program as a condition for which a treatment could very significantly alter the natural course of the disease. I appreciate that this is not a perfect definition, but this was our approach. And the second tier, if I might say, of this definition was to discuss with the expert of this disease and to say, look, if tomorrow I start bringing you pre-symptomatic cases, will you be happy? Will you know what to do? Will you consider that I'm doing something good for the families? And believe it or not, I mean, that helps a lot to define what we call maybe not a treatable condition, but a condition that was eligible for our program of treatable conditions.
Thanks for that. I think it is so important. It's a very simple question, but absolutely fundamental to the issue here. So the next question I'm going to take is for Anne, and I will get her to answer it in due course, but this is from someone who's chosen to be anonymous, and she said, considering the NSC puts so much weight on not screening due to causing more harm than good, will the NSC carry out work to see what the thoughts are about newborn screening in the general public? Why are they not more concerned about doing good and saving children? So I was wondering if any of you in your work had come across sort of social science research looking at this, and we often get a lot of social scientists at our events, so if they do know about this research and the panel don't, then please do post links to it in the chat or something. That'd be really helpful. So Nick.
Thanks, Sarah. I don't have a kind of an up-to-date report to refer to, but I thought it might be worth discussing the types of harms that we're talking about here. So one of them is a false positive, and that is where a family might be told that they might have the condition and they need to come in for a specific condition, and they need to come in for extra testing. And then they're told that actually that was a false alarm. Another one is diagnosing a condition before it begins to take effect. And the perceived harm there is that it might damage the relationship between parents and the child early in that child's life, especially if the first treatment might need to be given a year or 2 years after birth. And I'm sure there are some others. I think we do need to review what society thinks about these, especially in the context of the kinds of treatments that that we're seeing coming through now. So Laurent spoke about gene therapy for SMA and other treatments. These treatments are coming through thick and fast, we all saw on the news when the UK started using one of these treatments for SMA. A baby called Arthur got a treatment, and we started getting queries then about how can I get my newborn baby screened for SMA. And I wonder whether, as our society moves towards understanding more about genomics, more about preventative health like vaccines and so on, that we might start changing our view. I've certainly, working from home, more and more people are hearing me do presentations on screening and so on. And one of the things that most of my kind of this world friends are saying is, wait, so just a small false alarm is holding us back here. And I don't know, a lot of my friends with children say, this is a kind of a fact of having a child. You get a false alarm every now and again, and then it's all over, and that actually brings us together. So I don't know how recent the research is that the UKNSC are using to make the case for the level of ranking that they're giving to harms, and to define them and check them they match society's priorities. But I'd certainly want that to be some of the most up-to-date research that they're using.
Thanks, Nick. Will, do you want to come in, or Laurent, or has Nick covered it off?
Well, I could come in, certainly. So apologize. I'm a foreigner. I'm a newcomer, so I should not, be too negative. But I've just this experience of spinal muscular atrophy, and for me, the difference is such. I mean, between a patient who has been treated before and after, and there are so many evidences that when you have a discussion with a committee that tells you that there is no evidence because there is no double-blind randomized placebo-controlled study, because there is no different studies, but there is a very famous example in methodology, which is patients jumping from a flight with or without a parachute, right? And you don't need a double-blind randomized placebo-controlled study to demonstrate that there is a difference. And so, and then when you show videos that speak to anyone with common sense, then you're told, well, videos are not evidences, which is to a certain extent true. My personal feeling as a foreigner newcomer in the UK is that this balance between the fear to harm and the wish to make something good is slightly imbalanced towards the fears, because we consider the risk to harm, but when we are not acting, when we are not doing what do the US, the Germans, the Belgians, the Australians, the Japanese, the Spanish, every 5 days there is a patient will get a very significant disability for the rest of his life and a family behind, and this is harm also. And I think we should really consider that. And the process of implementing a pilot was 6 months in southern Belgium. It transitioned within the law in 3 years, and now it's in the official program. In UK, I'm working now for 2 years on the pilot that will finally start, hopefully. But it's very hard, to be honest.
Yep. I can see you nodding, Will. Was there anything you want to add, or?
Yeah, no, I mean, I totally agree with what both Nick and Laurent have said. I think, it's very hard from a kind of patient community to see this disconnect between, between one country and what's happening in the United Kingdom. The numbers and the barriers. When MPS 1 has gone twice to the National Screening Committee, and both times it's been turned down due to a lack of evidence, partly around the applicability of the test, but also around about the lack of natural history. But it's been adopted in many other countries, and what is unique about our country? The disease is a disease, and that the robustness, I value, does seem a bit out of context when other countries with established healthcare systems have adopted these diseases on their newborn screen.
Could I just add, Sarah?
Sure.
We're all not really members of the public in this context, and so maybe, of course, we would all say this, but that kind of adds value, adds the importance that we do need to be going out to check what the general public do think. And if the UK NSC can provide a really recent, very strong survey that says actually the public aren't that interested in screening, then we would have to accept that. But I suspect it isn't the case. If we can do that survey, it would be very good.
So I'm going to use my chair's prerogative and ask a question of my own. Now, Nick, in your presentation, you mentioned something called the Archangel campaign, or I saw it on a flash up on a slide, and I was wondering if you could give us a bit more information about that and what that is.
We at Genetic Rights UK support this campaign, the Archangel Newborn Screening Review campaign, which is a group of 13 condition-specific and umbrella patient organisations, including Niemann-Pick UK, led by Archangel MLD Trust, and in collaboration with Nikki Aitken MP. There are three great asks there that we think can move the needle on this and make a difference. And they're all by the end of 2022. We hope to see a formation of a dedicated team of newborn screening experts. And that touches on the point I was making around how maybe we need to look at these a little bit differently compared to how we look at other programs. That we need to establish a review process that automatically accepts a wide range of evidence currently available from validated and reputable sources. And Anne was asked about this. Will the UK NSC accept evidence from other countries? I think the reason that's an interesting question is because in the past, evidence from other screening programs that have been running for years haven't quite met the bar for the UK NSC. And then the last ask there is about having a much more timely process, and that might get us out of the problem that we've got with SMA, which is that a medicine was authorised at the beginning of the year, but it's not until next year that we start thinking about whether or not we can have a newborn screening programme. There's
a question from for Will, from someone who's chosen to be anonymous. They say they completely agree with you. That's always a good start. That the whole family should be taken into account. So why do you think the NSC doesn't take into account the other family members, which can be far-reaching and save many children now and in the future by, for example, having reproductive choice? But yet the NSC refused to take the other sort of family members into account.
So certainly within the guidelines for the National Screening Committee, they make reference to taking in that, but it's very much they make reference to taking into the broader family impact, including reproductive choices. But it's very much after, there is a precondition that there has to be a disease-modifying therapy, and then this is a secondary thought. Now, I would still agree with, I think that's a valid principle. I think the individual affected and the need for that to be a meaningful diagnosis for that individual is very important. But I just feel that the weighting of those two points, it needs some adjustment. As I said before, these conditions, almost every condition that sits on the newborn screen truly affects families. I mean, the impact upon Sam's brother and sister, in many respects, is as great if Sam. Sam doesn't have an awareness of his condition. His brother and sister do. And obviously has a huge impact upon his family and his friends. So to not give that sufficient weighting just doesn't make sense. And and I think that's part of what's being incorporated in some of the Archangels, as well as the timeliness review. It is a step back and look at some of these challenges. It is why Niemann-Pick UK is also supporting the Archangel proposal.
So, thanks for that. So we have had some questions from Francoise Shenfield, and she thinks there's a strong case for implementing screening in the UK. I think she's referring to SMA here, and wants to know what kind of lobbying that you're doing, Laurent, in addition to the petition. And she, as a corollary to that, she wants to know which European countries are doing this screening now.
So actually, as European countries, there is Germany, Belgium, Italy, Norway. Now it's Poland. It's in the Netherlands and will start next year. There is a pilot that will start in France next year, also in the Luxembourg. So yeah, a growing number of countries. Regarding lobbying, all stakeholders in SMA are on the same line, which is, quite a good sign. And together we have formed SMA NBS Alliance, and we have had a couple of discussions with the NSC, who is going to review the evidence in 2022. We're starting a pilot in Oxford, in the Thames Valley, to screen SMA. And this is, of course, an important part of the evidences to produce, to show that it works in a UK setting. And I think that we need to take actually any opportunity to explain the public. And that's why actually we raised this petition. It's not because we think that with 10,000 signature or 100 signature we will change anything. But I truly believe that most of people are happy to consider screening for treatable conditions when it's safe, when we have a very clear idea of the number of false positive and false negative. And then when you discuss with people, I mean, they balance the fact that you look for exon 7 in SMN1, or you take a risk and you make a risk of having a child with SMA who is not treated before the symptoms. I mean, most of people with common sense don't see where is such an issue. And I think that is an important point to consider. So that's actually the kind of lobbying we're doing. We've been part of several panels, and the beauty of being such a large alliance is that we can, appear at different congress and panels like this one.
Great, thanks for that. So then we have a question from Zosha Mijbrodka. It's embarrassing that I can't pronounce your surname, Zosha, when I have introduced you many times at our events, so apologies for garbling your surname. She says there's an argument that if only specific conditions are looked for, a much cheaper way of screening could be done using targeted DNA analysis without subjecting babies to whole genome sequencing without their consent. Hopefully this type of option will be considered alongside whole genome sequencing in the evaluation. I wonder whether anyone else wants to come in on this, on that point. Perhaps Nick.
Yeah, and I think it's an interesting point, Sasha. I mean, I don't know the answer, and that's because I'm not a clinical geneticist. But I think it's good though that we have 18 months or more with Genomics England looking at this and allowing all stakeholders to feed into the process, and make sure that when we do take the step of using a new tool in newborn screening, we make the right choice for society and for all stakeholders in the rare disease world. I wouldn't want to see the whole rare disease world wait though before making changes using the traditional metabolic screening techniques using tandem spectrometry and so on, and specific single gene targeted testing that's approved by the UK NSC. while that 18 months deliberative process happens, we do need to press on and use the current system, make sure it's working right, and authorize as many new conditions as the system decides are necessary. So I think they're kind of two separate things that I'd like to see work in parallel and feed off each other. The more newborn screening we do using traditional techniques will surely build a better environment for screening for what could be a much bigger number when we move into genomics.
I fully agree with that. So when we started our program, Baby Detect in Belgium, we carefully considered both options, whole exome sequencing or targeted sequencing. We had a lot of public involvement, and I can tell you that whole exome sequencing is something that people have quite some concerns about. The things as they are. The second thing is the cost. The cost is still lower with targeted sequencing. The third aspect is the data storage, which is a nightmare when you go to such volume. So when everything was considered, at least in our little country with 55,000 newborn per year, it appears to be quite more simple to go to the targeted sequencing, which also, you know, as on a philosophical point of view, is more clear. We go to the mutations that are known to be pathogenic in the genes that are known to be pathogenic. Of course, there are filters that you apply to whole exome sequencing, but in the mindset of it's quite different. So that's why we finally decided to go to the targeted sequencing approach.
Great. There's a question from Victoria Miller. How do you approach ethical consent for participation in the pilots that you've mentioned? So I know you've put something in response in the Q&A, you've typed it in, Laurent, but I think it'd be good to sort of flesh that out a bit. So if you could lead on that one first.
Well, actually, it's interesting because it depends from country to country. In the UK, we need to have an opt-in approach, which means that during the ultrasound that are conducted during pregnancy, the ladies are proposed to be part of a study, so they have to sign a consent, and this signature can be electronic. In Belgium, we had a long discussion with the ethics committee, and they agreed for an opt-out approach. And they considered that screening is a kind of global approach. And then parents are told that they are screening, that there is a list which is available on the website of the government. And if they are willing to opt out, it's their right. They just tell the midwife. And if they don't, they go for. So it's a complete different mindset. The beauty of the opt-out is that it's much more simple and much cheaper, because a pilot where you have to hire an army of midwives to get the lady consenting is extremely expensive. Difficult to start, because either you have the midwives who are and you have created this network, which is our chance in Oxford, either not, and then you have to start hiring a midwife per hospital, and then the midwife who's consenting get pregnant herself, or is sick, or out of office, or has COVID, or needs to self-isolate, and during this time, who is consenting the ladies, right? So it brings kind of logistical nightmare and difficulties that could end up in patients not being screened. So one more time, we should consider that there is a real ethical balance. But to answer shortly the question, today it's an opt-in scenario with midwives consenting the ladies during the pregnancy.
Will, as a parent, what do you think about this issue around consent for participation?
Well, I think the thing with consent is obviously consent needs to be meaningful, and that can be very challenging. when you're talking about diseases. You know, it's a very hypothetical scenario with regards to the disease that your child may have as a result of that you're going to be screened for, and it's sometimes presented at a time when that's not what you're thinking about as well. So you know, I think this is one of my concerns, and certainly, you know, I mentioned about the Screen Plus program, which is being done in New York. So there's 14 diseases on there, and I think even if you're a metabolic clinician, you'd struggle to rapidly describe all 14 and all of the treatment options for that. So I felt when you're saying you're going to consent individuals to be involved in a trial that involves 14 different diseases, how meaningful is that? And I would agree. I think sometimes there can be a little bit of a disconnect between you know, the potential sensitivities of a minority, and in fact, the vast majority of people whose views on this would be, Nick said before, it's really important to have this societal outreach and find out what people think about these things. Yep.
I often find that going on local radio talking about these things flushes out the public opinion that you don't, you know, normally perhaps come across, and so perhaps you should all be going on local radio to talk about these things and taking some sound bites, but that won't amount to evidence, just anecdotal. There's another question from someone who wanted to be anonymous, asking about the dangers of screening out babies with diseases and illnesses and using it as a form of eugenics. Does this send signals to a genetic underclass who are existing with this condition? Is this a cheaper option for governments who are strapped for cash than providing adequate financial support, DLA, respite to loving parents and families looking after these children? So I'm going to throw that to you first, Nick, because I'm sure that's something that comes up a lot at Genetic Alliance UK.
Thanks. Yeah, I think it's a useful question for discussion. So first of all, this is not screening out. This is identifying a condition that a newborn baby has, and giving, in most of the scenarios we've heard today, giving that newborn baby the best chance of life. If we kind of take a step back and consider that occasionally newborn screening will give a couple information that would then allow them to consider their environment and make an informed choice that they might want to use a reproductive choice technique to avoid having another child affected by that condition. So if they choose to have another child, to choose to avoid that child being affected by the condition, then there may be fewer conditions, fewer people born with said condition. And I think that where I go to understand that question is always to our membership at Genetic Alliance UK. So we have more than 200 patient organisation members. 99% of their time is spent helping families who have children or adults affected by conditions have the best possible outcomes. So accessing medicines, accessing support in society, in schools, care at home, information, treatments, and so on. That's their focus. But when we go to them and ask about pre-implantation genetic diagnosis, for example, or other reproductive choice techniques, they're also in support of that being an option on the table for informed choice. So this is a group of people who are connected to those living with the condition, essentially telling us, please carry on, making sure these options are on the table, and always with that emphasis of choice. So where certain couples choose that they would like to take the option to have an unaffected child, they should be allowed to do that. And that's a message coming loud and clear from people living with rare and genetic conditions.
Great, thanks, Nick. Do either of Will or Laurent want to come in? I think Nick's really given that quite a full answer. So I'm going to go to a question from Amber Gardner, and that's for you, Will. Thanks for your talk. As a genetic counsellor, I strongly agree with the need for more comprehensive newborn screening. Do you think that the NBS newborn screening through whole genome sequencing will be valuable to broaden the spectrum of conditions for which screening is currently available. And if you had this option when your son was born, do you think that you and your partner would have consented? Would you have had any concerns about the large amount of conditions screened for or incidental findings if you didn't have a previous family history of a genetic condition?
Yes, I mean, obviously, there's kind of quite a lot of layers to that, aren't there? And one of which, you know, we've gone over a number of times, which is, you know, the ambition and the potential for whole genome sequencing is incredibly broad, but there is a big disconnect between what that could achieve and where we're at now. So, you know, the barriers with regards to many of the diseases being adopted is nothing to do with the technicality of the test. It's to do with whether the risk benefit in the broadest sense, we know enough about the disease, and it's those barriers. So, you know, there are lots and lots of hurdles for the conditions which have a potential newborn screen that I think we need to overcome first. With regards to whole genome sequencing at birth, had that been available, I think the answer would be yes. I think, you know, I obviously I'm in a position potentially where I understand that, you know, there's a lot of uncertainty, and you know, and that's part of a wider need for public knowledge of many things in medicine and many things in biology are not black and white. And this is not unique to newborn screening, you know, as the concept of, you know, as genetic testing has been done much more widely and larger, you know, the number of variants of uncertain significance are increasing in all sorts of scenarios. So, and, you know, that communication of uncertainty is really important. And I think, but equally, I don't think it's, you know, this is not a unique to this world of genetic testing, this idea of genetic exceptionalism when it comes to testing. You know, there are lots of things that I do as a GP where we get test results back and they sit, you know, they said, what does it mean? You know, it increases their chance. You know, we have that quite a lot with a full blood count, and people have an MGUS where they may later on develop a hematological malignancy, but they probably won't, and we're going to monitor you. So although it needs to be taken with great caution, I do think that one can be overly reluctant to explore these things, because I think there's a great opportunity.
And I'm going to go to Bernd Schwan, who says, to me, the question is rather how to screen than what to screen for. Currently, quality assured newborn screening in the UK already produces unclear results in many cases. How can we reduce uncertainty in the process?
I think that they are very good cases for newborn screening, and there are conditions in which the screening is not as easy, right? And where you have overlap between cases that are not really disease and that are just variation of the norm. So we must be aware of that, and there are conditions for which of course things are much easier, and I took the example of spinal muscular atrophy, but they are all possibilities. One way to do is, of course, to have two approaches at the same time, and that's why I'm strongly convinced that today biochemical testing cannot be replaced by genetic testing. It's much too early, but both together could be extremely helpful in assessing and getting less false positive and less false negative. So I think that we need not only to consider the targeted sequencing of the whole exome sequencing as potential approach for new diseases, but also to be more precise, to be more accurate in the conditions that we are screening today.
Okay. Nick, you look like you're going to want to say something.
Yeah, just to add to that, I mean, my old boss used to say, perfect is the enemy of good, and I think that that's a useful phrase to use now. We should always be trying to improve things, but that shouldn't necessarily mean that we don't progress. And each time we do take a step forward, we need to be very careful that we're not making the situation any worse and taking every opportunity to make it better. But we should still try to progress nevertheless.
Yes, and don't make perfection the enemy of the good. I think that's right.
Is that's the proper quote? Thank you.
Yeah, that's, well, it's something that we say very often in our office, I have to say. So there's another question for, I think, Laurent, from someone who's anonymous. Why do you require whole genome sequencing for spinal muscular atrophy? Surely with the rate of incidence, a targeted test would be more cost effective. So Laurent, the floor is yours on that one.
I probably wasn't clear, and I'm sorry for that. So of course we don't conduct whole exome sequencing for spinal muscular atrophy. It's a PCR based, which is very specific of the exon 7 of SMN1 and much cheaper. So no, it's not whole exome sequencing.
Every 5 days, an SMA baby is born. What's sobering thoughts? When can we have carrier screening and newborn sequencing panels? Laurent, as you were partway through thinking about that one.
In Belgium, we have both. We have carrier screening and we have a newborn screening. It's two different approaches. The first one to consider is that carrier screening is really socially oriented towards an educated class and a wealthy class. Myself, I have 2 kids. If I wanted to have a third one, I would be quite attracted by carrier screening, to be honest. But most of the ladies, of the mothers of my patients, they've never seen a doctor before being pregnant. They never asked the permission to a doctor before being pregnant, which means that with carrier sequencing, you actually target an educated and more wealthy class. There are other things that you cannot capture with carrier sequencing, like for instance, neomutation, or people who have the 2 copies of the same gene on the same chromosome, which makes an allele completely free of the gene, right? You do not also capture kids who are not the biological infant of the fathers, right? So there are several cases that you do not capture, and for many of them, you have a social bias. The beauty of newborn screening is that you don't have a social bias. So far, the carrier screening program in southern Belgium, in Australia, and in Israel, because it exists in these 3 countries, have not decreased the incidence of spinal muscular atrophy, which means that it can help. It can help people who can get access and who are willing to get access to carrier screening to decrease their risk of having a child with a disability. But so far, it has not been demonstrated to really decrease the incidence of the disease. And you have a solution which is really oriented towards a more educated and wealthy population. So the beauty of newborn screening is that it's universal and that it's socially equitable.
Great. Nick or Will, do you want to come in on that?
I absolutely agree with Laurent's points. I think it seems unlikely on the NHS that it would be available on a population level. However, that is a kind of a jump-off point to talk about direct-to-consumer testing. There will be people that do want to check whether they're carriers to this, and will then have to jump into the murky world of trying to work out what a direct-to-consumer test is actually testing for. And I think we do need to look at the labeling of those tests and make sure that the consumer in the UK is able to be certain that when they have had a carrier test, they are actually receiving the results and understanding them, and what a negative is, knowing what you tested for and understanding what a negative result means. And I don't think that's very easy at the moment in the UK.
No, absolutely. So We have a question next from Victoria Headley for Nick. Nick, having a high quality, rigorous system is obviously important, and ideally that's what we want for all conditions, but I'm guessing the general patient perspective would be that it's better to risk false positives or false negatives or not having an excellent end-to-end system in place than lose that chance for early diagnosis and all that that diagnosis brings. Does your membership feel this way, e.g. better to include the condition in newborn screening, even if the system around it isn't perfect? That's a
hi,
really
Vicky.
nice question.
Yeah, really, really good question. I think, and it goes back to that perfect being the enemy of good thing, that and you can't build perfection from nothing. So you need to start somewhere and then build towards a better and better and better program. So if yes, I mean, I think let's start with a system that we think will do a good job and build the pathway around it. You can't create a pathway when there's nothing feeding into it yet. So absolutely, great point.
Will, do you want to come in on that one?
Yeah, I mean, that's certainly I would say that a little bit like we said before, you know, perfection is the enemy of good, and one of the challenges sometimes is often good established pathways, specialist centres are actually only set up when there's an established cohort of patients. And if you haven't got that cohort because you don't have a newborn screen available to identify these patients, you don't have the suitable pathway because these patients don't exist. These early symptomatic patients don't exist, or equally the numbers of patients aren't there. And certainly one of the things that we found in our disease area is that you often need to get to a critical mass to actually get to that point where the interest in developing therapies is there. So there can be an element of where the identification of patients does enable, and having a larger cohort of patients enables the services to be, there is increasingly a need for the service, and then the service is there, and that service and the treatments are developed for the benefit of all patients who were was existing and those subsequent to that.